how we went about making the 2030 commitments for the Republic. I came all the way to tell you this story, but it's a very compelling story. It's a story of collaboration. It's a story of partnership. It's a story of bringing the nation together to tell us what they want for us to be in 2030. So the background is that we were moving from the FP 2020, as you all know, and we needed a very strong commitment that was transparent and accountable, and therefore we needed to involve all the partners, all the stakeholders in the process. We had, this list there is not exhaustive. There were learning institutions that were involved, regulatory bodies, youth and youth networks, CSOs, government agencies, and devolved government units. We held a National Leaders Conference in May of 2021. It was a virtual meeting that was very, very well attended, and the Global Secretariat participated and shared the recommitment process in the facility sub-theme of that conference. So that is the background. What were the advocacy interventions required for this commitment?
Nous avons participé à la préparation de cet engagement de planification.
Were in FP 2030, and we did a draft document that was shared in an FP advocacy technical working group, a forum that brings together all FP implementers for validation. I will show you how we use data to develop the 2030 commitments. Now, moving from 2020 to FP 2020 to FP 2030 required that we take stock of where we were as a country, and that is recorded in the document called FP 2030 Achievements, Best Practices and Lessons Learned in Kenya, which we went through as a technical committee to understand what it is that we had done well, what it is that we were missing, what it is that we had failed to achieve. And in that technical meeting, we had focal points from government, development partners for health in Kenya, youth representatives, and so on. We also looked at supplies data from the National Family Planning supply chain. We also looked at the services data from the National Data Warehouse, and we engaged technical officers in writing workshops to put those commitments together. We also carried out a survey, an online survey targeting the youth, so that they could tell us what their concerns are moving forward in family planning. After we did the commitments, it was important to involve the top leadership of the government, the Ministry of Health, and therefore it was important for us to know what would be our entry point. And we realized, in fact, that the country right now is geared towards what we call the Vision 2030. And we had to find a way of showing that these commitments are contributing to the achievement of that vision. And that became our entry point. We talked to the ministers of health, the ministers of the National Treasury, because there was a commitment in terms of financing that was needed. And we got a buy-in from them, and they agreed with the commitments, and they endorsed the commitments in the launch ceremony. So what are some of the lessons we learned? One, it is not easy to get political leadership involved in technical commitments like this. They require a lot of advocacy. They require alignment with the national priorities that exist. They require alignment with national strategies that are in place already. And that is how we were able to get the leadership to endorse them, because we aligned them to the existing Vision 2030 activities. Involvement of stakeholders is expensive and time consuming, but it has to be done. If you leave a group out, you'll not succeed in making commitments that everybody will rally behind. It is critical to get buy-in from both the levels of government. In Kenya, we have a devolved government of national government and county governments. County governments are charged with the responsibility of delivering services to their people, health services. And without them, through the Council of Governors, it would have been impossible to make commitments that would be representative of the country. Youth participation is critical. The young people were physically present in all the meetings, and their voices were heard and their concerns were taken seriously, and they went into formulating the 8 commitments that we did come up with. Taking lessons from the previous commitments of FP 2020 was also crucial. We were able to see where the gaps were, the things that we were unable to achieve at that time, and we changed the way we viewed things. And when it comes to the strategies, because for each commitment, we wrote the strategies that we're going to follow to achieve them. We avoided the pitfalls that we saw in the FP 2020 implementation. Now, going forward, we have developed an action plan to start implementing our vision, to start implementing our commitments. And we are hoping we'll be able to have biennial conferences to take stock of how we are implementing these commitments. There are 8 commitments, which I will not go through, and each of the commitment is accompanied by strategies and actions and indicators that we're going to track. And we have an organization that is dedicated to tracking the commitments going forward. So that is the story of FP 2030 commitments in Kenya. There's the story of unity, the story of collaboration to come up with something we can be proud of come the year 2030. Thank you very much.
I would like to especially thank you for saving me some time. And you know, when we talk about accountability, the most important thing is everyone is accountable. It's not only the policy makers, it's also the service providers who are accountable. For any unintended pregnancy, is it not only because the policy was not there, the budget was not there, or is it also because the service provider did not have the training, service provider did not know how to do counseling properly, or is the mother-in-law or the husband also accountable? When we talk about accountability, we have to talk about accountability at 3 levels: the policy level, the service provider level, as well as the community or family level. And then only you can talk about whole accountability. I'll go to the second the speaker now. Barnabas Abok is the head of region for FCDO funded women and integrated sexual health, Lot 2 of IPPF. In this role, he provides program management oversight to a portfolio of 5 countries, and these include Ethiopia, Tanzania, South Sudan, Somalia, and Sudan. These happen to be the countries where I worked a lot earlier. So I would love to hear from your experience. During this session, he will be sharing experiences of Wish to Action, a program on improving value for money. And this is actually not based on a study, but rather an operational experience. So there will be a lot of operational experience sharing today. Thank you. So Barnabas, the floor is yours. And you have 15 minutes.
Good afternoon, everyone. So this afternoon, I would like to share with you the experience of the WISH project. WISH simply stands for Women's Integrated Sexual Health Program. And it is a UK aid-funded program through FCDO that seeks to scale up access to sexual reproductive health and rights in Africa and Asia. On the program, we have 4 outputs. Our first output is on individual choice, where we seek to build community support for SRHR and create enabling environment for access to SRHR. In the second output, we seek to build national ownership and support for sexual reproductive health and rights. And in the third output, we seek to scale up service delivery through different approaches and different strategies. And in doing all this, in our fourth output, we seek to generate evidence that can be shared across countries and across programs. So like any other program of this magnitude, value for money is a very important aspect. And in this program, our understanding or our definition of value for money is actually making the best use of the resources to achieve the highest impact. We premise our work around value for money on the 4 E's of value for money, which are economy, simply meaning spending less, efficiency, meaning spending well, and effectiveness, meaning spending wisely, as well as equity, which is spending fairly. Now, for many sexual and reproductive health programs, value for money frameworks is not usually prioritized. If you look at a service delivery program, you will realize that a number of them have logical frameworks that they use to monitor performance. Others have quality of care frameworks to monitor the quality of service delivery, but not so many usually have value for money frameworks. And so as a program, because of our desire to ensure we track value for money properly, we did go through a process that then resulted into us having a value for money framework that has indicators which we can use to track our performance on value for money. And so we had an initial assessment which culminated into development of the value for money framework and organized capacity building sessions with our implementing partners to sensitize them and to make them understand what is in the framework. And on a regular basis now, we measure our performance based on this framework. So what is in this framework? In the framework, we have guiding principles that are aligned to our program strategy. Some of them include sustainability, access, risk, integration, quality, learning, and innovation. We also have some of the key approaches that we use to ensure value for money and some of the tools that we have to monitor and track value for money. I'll briefly talk about some of the measures that we use in tracking value for money. On equity, we track the unit cost of the services we offer, especially to clients under the age of 20 and those living in poverty. On cost effectiveness, we track cost per daily averted, and on effectiveness, we look at our performance against the key performance indicators, as well as the policy changes that we have informed. On efficiency, we look at the unit cost per FP user, as well as the unit cost per CYP. And on economy, we look at the savings we have made through different strategies in the program, as well as the unit costs per training we conduct. And so on a regular basis, on an annual basis, we conduct a VFM assessment and we collect data through our monthly and quarterly reporting to inform this. So briefly, I'll just share with you some of the results or how we are performing on value for money to date. So as you can see on the graphs, when we started the program, before we put in place the value for money framework, our costs were pretty high. This is informed by the fact that at the beginning of the program, we had to make a lot of investment to put systems in place to run the program. But over time, through tracking our value for money performance and through adapting our strategies, we are seeing a gradual decrease in some of the indicators that we track. In the recent times, because of our desire to improve on equity, we have started seeing a slight upward trend in these indicators. Briefly on how the countries compare. So on cost per CYP, our lowest performing country has been Pakistan, and the highest is Somalia. So why would Somalia be the highest? Because it is a challenging environment. The cost of operating there is high. You have to put a lot of security considerations, so that increases the cost of implementation there. If we look at the cost per service to people under 20, our lowest country is Sudan, and the highest remains Somalia. So again, because of the reasons that I have already highlighted. So briefly on the different E's of VFM. On efficiency, we have seen a significant decrease in a number of countries that initially had higher costs, like Burundi, Malawi, Mozambique, and Pakistan. We've seen a decrease in year 3. Similarly, South Sudan and Somalia, which are the countries that have the highest costs of implementation, we've also seen a slight decrease in year 3 based on the adaptations in the strategies that we have implemented. On cost effectiveness, we can see that the cost per DALI for the program has reduced in year 3 by 50% when compared to year 2. And when we compare our performance against other programs, we can see that we benchmark so well with other programs of similar nature. On equity, we look at different elements. And so we look at cost per client living in poverty, cost per client under the age of 20, and we can see from the graphs that this has also been decreasing. So what are the key messages or key takeaways that we get from our experience of implementing this framework? One, value for money monitoring is very critical for strategic decision-making in a program like this, and even in national family planning programs. And for you to implement a value for money framework, you must be willing to change the way you operate and the way you do things. Now, we would have wished we developed the value for money framework early during the program development. And so we would encourage anyone willing or desiring to develop a value for money framework to do that as early as possible. And it requires a lot of effort to ensure that this is embedded into your day-to-day operations, and you must be willing to adapt your program from time to time based on the information you get from your regular monitoring. Thank you.
This is indeed something very promising and something very interesting, and I'm sure a lot of us would like to get more details about this framework, and I'll be writing to you soon. Okay, and this reminds me, you know, when I think it was 2003, even before South Sudan was born, we had been working with Somalia and South Sudan earlier, and the context, as you rightly described, is very challenging. Okay, thank you very much, and again, thank you for sticking to time. The third speaker is Laura Hurley. has a lot of experience. I'm not giving you the years, how many years of experience she has, because we want her to look young. So she has a lot of experience in public health and is currently a senior technical advisor family planning with Palladium. She has supported family planning's costed implementation, plan development, costing, implementation, and performance monitoring in a number of countries, specifically Madagascar, Mali, and Togo. Ms. Hurley is a seasoned public health professional with expertise in health policy, advocacy, RMNCH, family planning, community health, and community participation. And she will be sharing the usefulness of costed implementation plans to countries' family planning programs. The floor is yours, and you have 15 minutes. Thank you.
Thank you for the introduction and keeping my age secret. I'm really happy to be here today, and I'm happy that we've almost filled the room on the last concurrent session of the conference. So thank you very much for coming. I'm happy to be here. So I want to understand my audience a little bit, but this is the low-tech option. I didn't set up a survey. So I'd just like to see a show of hands if you know what a CIP is. That's pretty good. And please raise your hand if you have helped support the development, implementation, or monitoring of a CIP. Smaller, but still pretty good. So it helps to know my audience. So I'm here today to present on behalf of HP Plus, the Health Policy Plus project, and USAID on a study we conducted this past year on the usefulness of costed implementation plans for family planning. For a bit of context, from the London Summit in 2012 and the launch of FP 2020 until the end of 2020, 46 of the 69 FP 2020 focus countries made commitments to invest in and strengthen their family planning programs. In support of these commitments, 41 of the 46 commitment-making countries developed at least one CIP. International donors and stakeholders have supported these countries in the development of various components of their CIP for family planning. And they've provided technical and financial assistance for planning, developing, and executing, as well as funding the actual activities in the CIP. The Health Policy Plus project has worked closely with FP 2020, now FP 2030, to help these countries meet their commitments to ensuring availability of family planning to their populations. During the 7 years of the HP Plus project, which ended this past September, HP Plus supported the development of 21 CIPs in 16 countries and supported implementation and performance monitoring in 2 additional countries. As FP 2020 started to shift to FP 2030, the global initiative led its partners to conduct additional analyses to support its vision. So in this vein, and since the HP Plus project was ending, we decided to conduct this study. So the objective of the study was to identify lessons learned from applying the CIP approach and provide recommendations to improve upon the process to better meet the needs of the family planning programs and the stakeholders involved. This slide shows the 10-step costed implementation process in 3 phases. So planning, development, which includes costing and gap analysis, financial gap analysis, and execution, which includes stewardship and performance monitoring and resource mobilization. For the methodology, HP Plus first conducted a desk review to ascertain which FP 2020 focus countries had made commitments and used the CIP approach. We then created an online survey for stakeholders in countries that had used at least part of the approach. The online survey was primarily quantitative, and we had multiple choice questions were used to gather information on if and for what purposes The CIP tools were used, and we had open-ended questions asked for clarification on tool use and provided space for suggestions on how to improve upon various stages of the approach. Our assessment defined usefulness using the OECD evaluation criteria shown here in the orange box. For the purpose of our assessment, we defined relevance as the extent to which the CIP processes responded to the country's needs, coherence as compatibility of the CIP with other priorities and strategies, effectiveness as the extent to which the CIP achieved its objectives, efficiency as the extent to which the CIP delivered results in an economic and timely way, and impact as the extent to which the CIP generated higher level effects, and sustainability is the extent to which the benefits will continue. The survey was emailed to over 200 CIP stakeholders in 40 countries, and data was collected last December and January. Survey responses were received from 47 people in 30 countries. Half of the respondents were from West and Central Africa, 33% were from East and Southern Africa, and 17% from Asia. We had a good diversity of roles represented, including government staff, implementing partners or projects, donors, local CSO and FBO, and youth associations. Of the 30 countries represented by the respondents, half of them had been supported by the HP Plus project. So for results, in the first part of the survey, the multiple choice questions gathered information on whether or not individual countries completed CIP steps and used tools created for those steps. So this slide shows that the 2 steps in the planning phase were conducted by nearly all 30 countries. The development phase were also conducted by the majority of countries, with a range of 77 to 90% of countries conducting each step. Phase 3 is where countries hit a roadblock, which is often the case with strategy and policy implementation. Momentum starts strong, but once a policy is launched, it can be hard to keep that motivation up for implementing and monitoring. Only about half of the countries reported providing effective stewardship, conducting performance monitoring, or developing a resource mobilization plan. While not shown in the graph, we were happy to find that countries supported by HP Plus reported conducting steps 9 and 10 at a higher rate than average, 67% for performance monitoring and 60% for resource mobilization. So in the second part of the survey, Likert scale questions gathered feedback according to the 6 OECD criteria. Survey respondents were given statements for each criteria and asked if they strongly disagreed, were neutral, agreed, or strongly agreed. So an average of 74% of respondents either agreed or strongly agreed to statements about relevance of the CIP to the family planning program. Key challenges were resource mobilization, performance monitoring, and the ability of the CIP to influence subnational stakeholders. Coherent statements received an average of 76% agreement. Key issues for coherence were alignment with budget priorities and alignment with non-health sector priorities, especially education. Efficiency and effectiveness scored the lowest at 60 and 62% agreement. The sticking points for both were statements about performance monitoring and resource mobilization. However, we were relieved to see that respondents from HP Plus supported countries responded more positively than average, with 70 and 71% agreement, respectively. For impact, respondents generally indicated the CIP moved the FP program forward, improved FP indicators, and helped their populations access family planning. But resource mobilization was a limiting factor for impact. Finally, sustainability statements received 71% agreement, but respondents from HP Plus supported countries agreed at 79%. Key challenges for all country respondents were sustainability of resources, but non-HP Plus countries, country ownership and capacity were also sticking points. So our key challenges are listed here. So country ownership remains a challenge, but we observe that capacity building of stakeholders can address this. 83% of H2+ country respondents agreed that FP stakeholders built capacity in health sector coordination and collaboration through the CIP process. Alignment of the CIP to government priorities and government and donor budgets remains a challenge. Lack of inclusivity was the most common challenge raised in the qualitative survey responses, with particular comments around youth and marginalized populations. Additional inclusivity will promote relevance to all family planning stakeholders, and it will support resource allocation. Performance monitoring thrives only with external partner support, as both resources and capacity are needed to do the performance monitoring. However, where CIP dashboards and final reviews were conducted, performance monitoring was deemed relevant, efficient, and effective. Resource mobilization remains the greatest challenge across all 6 criteria. However, 67% of H2+ country respondents agreed that stakeholders built capacity in resource mobilization through the CIP process. So I'm going to present some recommendations for moving forward per the OECD criteria. So for relevance of the CIP, countries need to ensure inclusivity through communication and dissemination channels and by engaging both health and non-health government officials, including subnational government actors, the private sector, civil society, and representatives of disabled populations, community, and religious leaders. For coherence of the CIP and to encourage investment in the CIP, we need to integrate its priorities and activities into government's existing procedures and align the timeline for planning and budgeting. For efficiency of the CIP, prevent duplication of effort by aligning the CIP process into existing Ministry of Health processes, structures, and dashboards. Several things can be done to improve the effectiveness of the CIP. First, it's important to foster stewardship and transparency among government officials and build the capacity of civil society to enforce enforce their accountability to countries' family planning objectives. In 2022, H2+ developed a new tool to promote stewardship for execution of costed implementation plan that's now in the FP 2030 toolkit. Second, it's important to ensure resources are available for periodic reviews, performance monitoring, dashboards, and using data for decision making. Based on results of the assessment, the most important strategy for impact is to ensure resources for the CIP. Thus, country stakeholders should prioritize CIP strategies and activities based on the resources that are available. The guidance for developing a technical strategy provides several suggestions for prioritization, including conducting a financial gap analysis to understand available resources and guide the prioritization process. Strengthening the capacity of stakeholders in budget advocacy to mobilize additional resources for CIPs will also support potential impact of the CIP. To promote sustainability, it will be important to strengthen the technical capacity of Ministry of Health officials. And that should include CIP development, costing, and performance monitoring processes. So to conclude, the CIP approach has supported countries in advancing their family planning programs and working towards their FP 2020 goals. Countries making FP 2030 commitments should make an effort to use the learnings from the last decade to advance their family planning agenda, ensure strategy execution, and adapt their strategies based on changing priorities and performance monitoring data. Donors and partners should support countries through capacity building in CIP execution and bolstering country ownership and government stewardship. These efforts will help the CIP approach have sustainable positive impact. The final report was published last month on the website, so it can be found here, or I can share my business card. I'm happy to send it out. So thank you very much for your attendance. Thanks again for coming.
I'm privileged to have such speakers. I don't have to remind them about the time I was about. So thank you so much. And there can be no doubt about the significance and importance of the costed implementation plans. And you rightly pointed out about the impact and sustainability. The world has gradually shifted from funding to financing. We are now talking about long-term sustainability of programs, which is independent of donor funding. And also it is important to remember, if you're talking about sustainability, we have to talk about national ownership. And national ownership comes with accountability. And accountability comes when programs are owned by the community. So community ownership, and as you rightly pointed out, capacity development, all these are very important issues. Thank you so very much. Now, coming to the fourth speaker, Achilles, the floor is yours. Achilles is a program officer at the Africa Regional Office of Partners for Population and Development, PPD. He is based in Kampala, Uganda. PPD, as you all know, is an intergovernmental alliance of about 30 countries in the global south, from Africa, Asia, Middle East, and Southern America. His presentation is going to focus on national health insurance schemes, which are strong catalysts in country processes to achieve universal health care, universal health coverage, and also access to quality services of family planning and SRHR. I'm not going to divulge the secret of your success because I don't want to tell them what happened. So he's again going to share some very good, very important experiences from the country and how they could mobilize policymakers to make a positive impact and shift to the program. The floor is yours, 15 minutes.
Thank you. Thank you very much, Dr. Vinit, and good afternoon, ladies and gentlemen. I appreciate so much your moderation, and I was whispering to you, let me tell the audience. I said, I think you're an expert moderator. I've found you in most of my sessions, and I want to ask you all to warn the public. They have come looking for a yes. And I'm not surprised that this presentation was accepted at this conference. But I must say how important it is for collaborative work. Thanks for the good introduction of myself and the organization I work for. But I was not alone. With my colleague Faith Kiateka, who worked then at Maristops, Uganda, we consulted near all the civil society in Uganda, and it's Uganda that sent us, and they recommended us. Everybody wanted to talk about this. And it was also closely read by a colleague from Reproductive Health Uganda, Richard, here in the house, and my colleagues at PPDR, Patrick Mujirwa and Ivana Chimuri, but most especially the Johns Hopkins University at Bloomberg, the AFP project, who really read through this work. I'm very happy, but once again, getting to a yes, but advocates as we are, that yes is a yes from a decision maker. And you know the 5-point message box in the FP Smart Advocacy, you go with your smart ask, and the decision maker will say yes, but. The yes I'm going to talk about has a but. So don't be disappointed if it's not completely a yes. It is a yes with a but. And why so many decades? 30 years of working, and stagnation is a strong word for universal health coverage. I'll talk about the background of health in Uganda and a few indicators, our intervention, what we did, how we did it, what we achieved, the yes, and what we learned. And Uganda, you read from the right, only 2% of Ugandans have a health insurance. And these are either commercial, from private sector, or community health insurances. This doesn't surprise you that the out-of-pocket expenditure is 41%. This is one of the highest. I don't know, I've not compared figures in the world, but in the region and in Africa. This means that when you're sick, you have to touch in your pockets, you go to your bank account, you have to pay. Many people have to sell their property, have to take bank loans, others die, others go late. And so this is very important as a figure and why we are talking about what we are talking about. Then, in Uganda, 41% of expenditure for health is financed by development partners, and only 17% of the expenditures are from government. This explains why access for health, quality health care is such a rare case. This is a country where you have a high growth rate of population growth, 3%, 5.4 total fertility rate, and so 44% of pregnancies are not intended. Although we have unmet need that is improving, 30%, and we have MCPR, the modern contraceptive prevalence rate, also improving. We have come from far in Uganda, but the highest indicator, and not this, is the 25% of young mothers or teenage pregnancies. This is extremely high. All this, you say, which country is this? This country has a strong commitment for healthcare and quality one. And we have seen it. The government in Uganda has the same party that has been in power for coming to 40 years. This and the election democracy, every year for the last 25 years, the party has had in its manifesto national health insurance for Uganda. And it was always repetitive there. It is in the plans and projects, the development plans of the country. But it has not yet been achieved. So what is happening? So what did we do and how did we do it? I must insist here to say that this has been a collaborative effort of work with so many advocates, nearly everybody in Uganda. But while PPDR, or Partners in Population Development, or FP with the Reproductive Health Uganda, together with Maristops, so that we need a national health insurance. But there's no national health insurance, there's no universal coverage without family planning. So we had two objectives. First, let us have a national health insurance approved by Parliament, and let us have family planning in there. This, you all agree with me, and has been done. Then we had collaborative efforts. These are Ramka plus Nutrition civil society platform in Uganda. Involves more than 100 civil society. All of them have been on board working on these two objectives. It is like one objective, to have Parliament pass this as a law, and that law, as they pass it, have family planning in there. So how did we do it? We worked, we capacity built along with the decision maker, which is Parliament. Members of Parliament, whenever they needed their help, we were with them. Ministry of Health, Ministry of Finance, Planning and Economic Development. We supported them to do benchmarking around the region. Uganda is the only country, I repeat, around that region of East Africa that doesn't have a semblance of national health insurance. We went all around. We learned a lot from Ghana and a lot from Zambia lately during the process of having family planning within the provider's package. But we also did lots in our way of working. We saw that, why don't we have it? Because the public did not demand it. People didn't know exactly how beneficial it would be to have their health insured. So we did lots of media campaigns, we wrote publications, we had support from everywhere to have the public create pressure to demand their government for the accountability for their health and their rights. And this happened through Parliament. The result is that, ladies and gentlemen, on that date, advocates in Uganda called each other and wanted to have a reception and a dinner because Parliament of Uganda passed a national health insurance bill that included family planning in the provider's package. So that was our yes, but it depends. That achievement after so many decades later on, so that the president then had to sign that bill into law. But we had the crucial private sector. The few private sector, the employers who employ others, did not agree with us, and they went to the president very fast, and they equated the premium that will be paid for the insurance to a tax. They told the president that if the people we employ are going to pay for their health through the national health insurance, it will make our doing business hard. So, due to that resistance, the president did not assent, alas, to this. So it didn't become law. So the yes somehow went back to a zero. The president then, so now this is where we are vindicated. Once Parliament passes a bill, there's no way it won't become law. The president can do a few things, can send it back to Parliament, and they revise a few things. But this didn't happen. There was a bit of illegality. But now what we have, he sent it back to the Ministry of Health after a lot of our engagement with that decision maker. We had partners. Yesterday, a colleague at dinner asked me, so do you have access to the president? I told her, in our advocacy, we send messengers, we send people who are influential. We sent lots of people to the president who convinced him with a lot of ideas and evidence, and now we have a revised bill that allows the employees to pay full package without being subtracted from their employer's package. So 2 weeks ago, before we came here, we had the First Parliamentary Council announce that the bill has come out now and is going to go through back to Parliament, and the road will be easy. So what have we learned as I conclude? Collective and collaborative efforts. We worked with everybody. We did lots of work, and everybody was engaging from their side and coming together and knocked at the doors of the decision makers. We also learned that we have to persist. 30 years, ladies and gentlemen, but extensively 5 years of that last parliament, when near every week or every month you had a big meeting, including engagements with the media. We learned that we have to announce this, to sensitize the population, to empower them as beneficiaries to demand for this, so their leaders will be seen to have to be accountable. Finally, two other important, and these points have been made by everybody, the decision-making process. Advocates know you have to talk to the decision makers, and we knew that, but we didn't know that it was going to stop at Parliament. What happened was not exactly what should happen. So we went to say, as I have said, sent influential people that the president listens to. We gave them all the points and what would happen if he gave his people health insurance. And now they have appreciated us as advocates, as president, as ministry, and all the others, including now the last point that we learned, whom to involve. We did involve the private sector, but they were talking a bit on the side. Now we have engaged them. We say, come around. What is your point? And they have agreed with us. now we are going to go ahead. Of course, they have modified that point. They will not contribute to the employee, but they subtract from him. This debate is going to happen in Parliament, but we have been told by the Minister of Health and the planners that this is going to be okay. There's no need for another certificate of financial implication, which is the greatest thing for such a bill. We have assured the government that this can be financed innovatively. And since you're not stopping me, let me take the last slide. This is what we sent around to people. Please come and listen to this. I also sent it to my wife, and she said, "Is this how you look?" And so she got it wrong. This picture was taken at ICFP in Kigali, and some years back. And while there, we came across, we went with Advanced Family Planning, AFP, and we are engaging in this. And then we met advocates from PAI. He said, PPGRO and GRG, you are the ones who are advancing this cause. So we mooted a plan, and we had a project called UHC Engage through PAI, which helped us a lot to augment the resources that we mobilized and to do partnerships with others, to do a lot of work together with Maristops, to do family planning into there. And this RAMCA, like I began with, represents collaborative efforts. Everybody, all Ugandans, there are quite a few Ugandans here, all Ugandans who are working for RAMCA have contributed to what I've just described. Ladies and gentlemen, thank you very much for listening to me.
Again, someone who didn't need to be reminded about time. Thank you. And by the way, you look younger than your picture. Okay, so that's why your wife didn't recognize you. Okay, when we're talking about advocacy, and it was a very good example of advocacy, I'm reminded of the 6 Ps that we usually use. The first one is partnership. We talk, when we have to do something, we need partners. We need peer comparisons, like they use comparisons with other countries. The third P is passion. You cannot just leave it in somewhere in between. Then you have patience, perseverance, and persistence. Finally, you reach where you want to reach, and this is a very good example. Thank you very much. We have 10 minutes, 12 minutes, for question and answers, if there are any, or any clarifications or experience sharing. Oh, yes. Do we have a mic somewhere? I don't want to part with my mic.
Yeah, this is Sunita Sharma, Director, Propel Health Project, USAID funded. Thank you very much for such excellent presentations. So my question is about Uganda, including family planning insurance package. So when you're saying including family planning and insurance package, what all is included? It is counseling, methods. I would like to know a little bit more about what is included in the benefit package.
Can we go first take 2 or 3 questions and then answers? Let's take 2 more, and then if there are questions, otherwise then we'll start answering them. Any other question? There's one at the back.
Thank you very much for your presentations. Mine is not a question, but a comment.
Could you identify yourself, please?
Oh, sorry. My name is Maureen. I work with Chapaigo in Kenya under the Challenge Initiative. My question, it's not a question, it's a comment. I'm hoping that the first presenter would be able to share the value for money framework, or if it's available somewhere, you can be able to share where we can get the resources.
Anyone else? Yes.
Good afternoon, everybody. My name is Marcel Sati. I'm from Nigeria, from the Budget Office of the Federation. My presence here is a result of advocacy and the passion of the Nigerian government to ensure adequate funding for family planning. Quite an interesting session, right, from Barnabas. coming here, the only name I heard at the airport was Barnabas. And hearing Barnabas today, the name just stuck with me. And Laura, wonderful one also, and Achilles also. I'm so much concerned with the issue of the CIP. How can we incorporate it into our own tools at the federal level? Because this has actually been an issue for us. We've had different engagements. The timing of a lot of programs doesn't fit the government budget because the government of Nigeria has a law, the Financial Regulatory Act 2007, that guides the operation of budget and budgeting process. Thank you very much.
Thank you. Would you like to answer the questions and then we can take another round? Yes, yeah, you go ahead first.
Thank you very much for that question about the inclusion of family planning in the provider's package for the national health insurance. And the answer is yes. We sat down and advised and studied the costs of what it would take. And so, because our biggest, I must say that we were very voluntary and express that let us not have this bill passed, this law, without family planning. And that's the lesson. And so we made sure that we have this inclusion. And we had benefited from lessons from especially Ghana that was struggling then. And they were sharing this experience yesterday. They passed national health insurance without including family planning. And due to the UHC Engage project that we had, we benefited from their lessons. Our struggle was to have the insurance. For them was to revise the insurance to include family planning. So we have it, information, counseling methods and services, and the whole spectrum of reproductive health service provision. We are extremely happy. We hope the new one that comes will still hold it. Thank you very much.
Thanks for your comment. We do have a resource portal, and I'll check if the VFM framework is one of the documents that is publicly available on the portal and let you know. Otherwise, we'll have to then upload it there and make it available.
Yes, so thank you for the question from Nigeria. I don't have a lot of experience in Nigeria. I've been once. But to answer your question, I think it's important that the CAPs are aligned with the health sector development plan, whatever it's called in Nigeria, at the federal level. But I know Nigeria is very large and very decentralized. So I think what's more important is integrating the key ideas into the state plans. I'm not sure what they're called in Nigeria, but one example that we have is in Malawi. The CIP goals and activities were integrated into their district implementation plans. So those are annual plans that help the districts really, engage and hold the district accountable for implementing that national plan. So that's one suggestion, is sharing of the Malawi experience.
Thank you. I don't want to stand between your lunch and this session now. We can have one more question? 3 more questions. Okay, these are the 3 final last questions. Okay.
Well, I have the mic.
Yeah.
Yeah, my name is Vernon. I work for IPPF's WISH program with Barnabas. Thank you very much for all your presentation. My question to Laura and probably Dr. Ndwiga, who is a policymaker, it's rather ironic that performance monitoring is not institutionalized as part of the CIPs, I mean, from your presentation. So what will it take to institutionalize performance monitoring as part of the CIP process? And what lessons can we draw from other programs? I mean, the HIV program, for example, has institutionalized performance monitoring, and those data collected are regularly used to inform program improvements. So what will it take to do that?
Hi, Bram Brooks from Pathfinder International, and I work with the M&E team. Excellent presentations to all the members. My question is, did you have any challenges implementing the VFM framework? When I looked at metrics such as cost per CYP, cost per DALYs, those aren't easy measurements that one can easily implement. So curious to learn some of the implementation challenges and ideally solutions to address some of those challenges. Thank you.
We have one question here.
Thank you. Rebecca Ross from Propel Health. For Uganda, I have two questions. For Uganda, noting that there are existing private insurance mechanisms as well as CBHI, what is done or what can be done, if anything, to leverage those existing schemes or integrate them or make sure they're complementary to the national plan? And for Kenya, noting that there are ambitious commitments for financing the FP program and commodities in the FP 2030 commitments, what strategies has Kenya taken to elevate family planning in fiscal dialogue so that we can learn from your experience?
Thank you. Okay. It appears now we are shifting from accountability session to session on financing and advocacy. Oh, everything is together. Okay, so who wants to go first?
Thank you for your question. Yes, indeed, we've had challenges. As I mentioned, we rolled out the framework way after the program had started. And so this meant that our M&E and finance systems had already been designed in a particular way. And so we had to then adapt to ensure that we gather the data we required that could respond to the indicators that we had. And that was a bit challenging. And because of that, we had to also use other avenues to try to answer our indicators, especially the equity indicators, for which we have then done other discrete studies to try and answer them, because our data systems, as they were initially designed, could not collect that information. The other main challenge has been disaggregating, especially the cost data. So in a program such as this, there are different cost elements. And so disaggregating and identifying the direct costs that then can be used in the metrics to assess the indicators has been a challenge as well. Thank you.
Yeah, thank you very much about the question of leveraging both private insurance providers and the community-based insurance providers. I didn't mention it all, but the community-based insurance providers happen in several districts in Uganda, about 15 out of the 150, and they have been there for quite a long time. And the areas where it has happened, it works very well. So this has shown that it is possible. It can be done. It has not been scaled up, and the only way to scale it up is to have it national and passed in Parliament. And this has helped us to make our case. And we have assured those colleagues who are offering the community health insurance that you are the examples and you are the ones who give us the data and evidence that this can happen. And they are included in the law that was not passed. And they are very happy with us, and they have been at the table in the discussions. The private healthcare insurance providers have also shown that it's possible, but it's extremely expensive. The package or the premium is extremely expensive, but it's possible for those who want it. they have been part of the pockets of resistance. They're a bit of the reason why this didn't actually happen, because by example, and from the region, we have seen it in Tanzania, where national health insurances have succeeded, the private health insurance providers have faded out. But we have engaged with them, and we have now at the table promised them, and they know now in the law that will come, if it's passed that way, that where national health insurance stops, they will begin. Whoever wants a bit more of the healthcare and the package provision will go to them, and they will really stay and keep at the table. And they are very happy with us, and we are engaging with them. And there at this conference, they have a federation of Uganda Healthcare Federation, and they have provided lots of evidence of how this will work. Thank you very much.
Okay, I think I have the last question. So you asked what it will take to ensure performance monitoring of CIPs. So thank you for that question. So I think it will take three things. Number one, resources. Our survey asked why dashboards weren't developed or why performance review meetings weren't held, and the answer was often there were no resources for that. So you have to plan ahead and set up those frameworks and budget for those. Number two, data. The CAP is broken down into various components. There's always service delivery data, there's always commodity data, but getting data on the enabling environment can be a challenge. Data on financing can be a challenge. There's always, you have the budget data, but what about the expenditure data? That can be a challenge. And then data for demand creation can often be expensive to get. So you often wait for the DHS, which is every 5 years or 7 years during COVID, and so you don't have that regular data. Third and finally, but the theme of the panel would be joint accountability. I think that stewardship of the government and then civil society holding donors and government accountable to these commitments in the CIP are important. Thank you.
Yeah, thank you very much for those queries. I don't think I'll touch on CIP, the expert has spoken. As far as financing our commitment is concerned, you'll notice some of those commitments go beyond the Ministry of Health. So when we do a medium-term expenditure frameworks meeting, all the stakeholders are represented, all the ministries are represented, and each one of them has to put money towards achievement of these commitments. If I could give you an example, we have a problem of teenage pregnancies, and it's one of our commitments to lower them. I don't know whether this is an acceptable level, but to lower them anyway. And we cannot do that just from the interventions of the Ministry of Health. It's not just family planning that will work. There must be Ministry of Education putting in resources to ensure 100% transition of students from one level to the other. The ministry responsible for agriculture and so on to ensure that the poverty reduction activities are taking place so that children remain in school and so on. So, but as far as family planning itself is concerned, there's a lot of advocacy that has happened in the last few years. We advocate with the Treasury, we advocate with the Parliament in the allocation of resources for family planning and reproductive health in general. And we have seen that work because we're in partnership with the National Council for Population and Development, who are themselves in the National Treasury Ministry. So we have seen an increase in allocation of resources as we transition to 100% domestic financing. We also activated a stalled MOU that had stalled in 2019 with the development partners so that we could activate a matching fund so that they could match the fund that the resources that are given by the National Treasury in certain ratios until they reduce to zero in around 2026. And that was signed with the government ministers and the representatives of the development partners. And it has been working very, very well. So in short, it's tireless, persistent advocacy that has gotten us where we are. Thank you.
Thank you very much, everyone, for your presence, and a round of applause for all the presenters. It's been a very interesting and informative session for sure. And I feel privileged to be among such a distinguished audience. Thank you very much.